Hey everyone, and welcome back to The Explainer. Today we're taking a definitive, deep dive into diabetic neuropathy. Now we're going to move way beyond just basic symptom recognition here. If you're managing patients on the wards, you know you need to deeply understand the why and the how behind this condition. This isn't just about rote memorizing a list of facts, it's really a clinical reasoning journey. We designed this specifically for medicine residents and focused learners who want to absolutely master the pathophysiology, understand the exact nerve fibers involved, and nail down those comprehensive treatment strategies, all based on Harrison's 22nd edition. So let's get into it.
Here is our roadmap for today. First, we'll look at the clinical burden. 2, the mechanisms of nerve damage. 3, classifying diabetic neuropathies. 4, ruling out mimics. And 5, comprehensive treatment strategies.
All right, let's start with Section 1, the clinical burden.
Okay, let's dive right into this. Just to put things into perspective, in India alone, there are over 77 million diagnosed diabetics. That literally makes it the diabetes capital of the world. But here's the truly staggering reality of that number. Up to 50% of those patients are going to develop diabetic neuropathy over their lifetime. Half. And because early nerve injury often progresses totally under the radar, the actual, true burden is probably even higher than that. We're talking about a massive, highly at-risk population where catching this early can literally save limbs, and frankly, save lives.
You know, there's this fantastic foundational quote from Harrison's that really sets the tone here. It says, the key clinical question is not only what nerves are affected, but also why this patient at this stage and what complications are likely to follow. That right there, that is the level of rigorous clinical reasoning we need to be applying every day. It's just not enough to document that a patient has numbness. We have to anticipate the entire trajectory of their disease.
Moving right along to Section 2, mechanisms of nerve damage.
And this brilliantly illustrates what's actually happening on a microscopic level. Think of our peripheral nerves like household electrical cables, right? They've got that protective myelin coating on the outside. And the vasa nervorum, those tiny little blood vessels supplying the nerves, well, they are the dedicated power supply. Diabetes doesn't just fray the cable, it actively destroys the power supply. So when the wiring is damaged and the power supply becomes totally unstable, what happens? The electrical signals become weak, they get distorted, or they just get lost entirely.
Now this damage, it's not just one single thing. It's a whole multifactorial cascading nightmare. First off, chronic hyperglycemia overloads what we call the polyol pathway. This creates excess sorbitol, which acts basically like a giant osmotic trap right inside the nerve, pulling in water and just wreaking havoc on the cell's balance. At the same time, advanced glycation end products, or AGEs, come in and physically stiffen the tissues. Then we get microvascular ischemia. That's damage to those tiny vasa nervorum blood vessels, which creates endoneurohypoxia. So now you literally have a low-oxygen environment directly inside the nerve itself. Add a massive overload of oxidative stress from reactive oxygen species to that mix, and finally, a total loss of neurotrophic support. The nerve actually loses the chemical maintenance signals it needs just to repair daily wear and tear. It is this vicious, self-amplifying cycle of metabolic stress and vascular insufficiency.
But how does all this microscopic damage actually look when a patient walks into the clinic? For you residents on the wards, getting the distinction between the specific nerve fibers involved is absolutely paramount. Let's break it down. The small sensory fibers, specifically those unmyelinated C fibers and the thinly myelinated A delta fibers, those are typically damaged first. And clinically, this manifests as burning feet, electric shock type sensations, and severe allodynia, which is almost always worse at night. So because these small pain fibers go first, patients might feel intense, agonizing pain long before they ever notice any numbness. Now on the flip side, when the disease progresses to the large, heavily myelinated A beta fibers, the clinical picture shifts. That's when we see a profound loss of proprioception, diminished reflexes, and severe gait instability. The patient literally loses their balance because those physical mechanical positioning signals simply aren't reaching the brain anymore.
Okay, on to Section 3, classifying diabetic neuropathies.
Now, what's really interesting about this is how distinctly these different types of neuropathy behave in practice. The most common presentation you're going to see on the floors, hands down, is distal symmetric polyneuropathy, or DSP.
This one famously affects the longest nerves first, which gives us that classic stocking glove distribution of sensory loss starting at the toes. Then there's autonomic neuropathy. This one is sneaky. It destabilizes totally involuntary functions, think wild blood pressure swings and delayed digestion. We also see focal and multifocal neuropathies, which give you these patchy, asymmetrical deficits like a sudden cranial nerve palsy. But hey, pay really close attention to this last one, treatment-induced neuropathy, which used to be called insulin neuritis. This is a wild clinical paradox where a patient experiences acute, excruciating pain right after a rapid, rather than a steady, improvement in their blood sugar control. The nerves simply adapt really poorly to sudden metabolic shifts.
When you're evaluating these patients, especially in high-risk diabetic populations, you absolutely must have your radar up for specific clinical red flags. Diabetic amyotrophy is a massive one to know. It presents as severe, usually asymmetric, proximal thigh weakness along with weight loss. This means there's an ischemic injury to the lumbosacral plexus. Bottom line, this is not your standard distal stocking glove neuropathy, so don't brush it off. Another terrifying red flag is silent ischemia. Remember that autonomic neuropathy we just talked about? Well, it can completely blunt the body's warning signals for angina. That means a patient can literally suffer a massive myocardial infarction without ever feeling the typical crushing chest pain.
Let's pivot to Section 4, ruling out neuropathy mimics.
All right, here's a critical, absolutely must-know word pearl. Vitamin B12 deficiency perfectly mimics diabetic neuropathy. I'm talking the exact same numbness and tingling. So why does this matter so much? Because metformin, which is, the single most common first-line drug we use for diabetes, can actually impair the gut's ability to absorb vitamin B12. You must routinely check B12 levels in these patients because, unlike advanced diabetic nerve damage, a B12 deficiency is easily treatable and totally reversible if you catch it early enough.
Another really frequent mimic is spinal canal stenosis. When you get nerve root compression in the lumbar spine, it causes radiculopathy. That means leg pain, numbness, and weakness that can look exactly like a focal diabetic neuropathy. So how do you tell the difference? A careful history is your absolute best tool here. Symptoms that worsen when the patient is standing or walking, but magically improve when they lean forward, that usually points right to the spine, not just the blood sugar.
To round out the complete differential diagnoses, you've also got to screen for chronic alcohol use because that causes a nearly identical sensory motor neuropathy. And definitely don't forget to check a TSH to rule out untreated hypothyroidism. Now, if the clinical picture is still a bit murky after all that, we turn to our key investigations. Nerve conduction studies and EMGs are great for checking large fiber function. And for those really elusive early small fiber neuropathies where the EMG is totally normal, that's where we use highly specialized skin biopsies to check the intraepidermal nerve fiber density.
Finally, Section 5, Comprehensive Treatment Strategies. So the crucial point here is this. How do we actually treat this? The treatment strategy has to be holistic. The absolute cornerstone, and I mean the non-negotiable foundation of all of this, is meticulous glycemic control. We are aiming for an HbA1c of less than or equal to 7%. Why? Because this is currently the only proven way to actually halt or slow down the progression of the disease, period. From there, we layer on things like lifestyle modifications, super rigorous foot care protocols, and really aggressive cardiovascular risk reduction. That means getting them on statins and maintaining strict blood pressure control. You just cannot treat diabetic neuropathy in a silo. It absolutely requires a multidisciplinary team approach.
All right, let's talk pharmacology, specifically for you residents writing these orders on the wards to manage that awful neuropathic pain. We use very distinct pharmacological tiers. First-line agents include pregabalin and gabapentin. These are great because they bind the alpha-2 delta subunit of the calcium channels to basically just calm those overactive, misfiring nerves. For first-line, we also frequently use the SNRI, duloxetine, and tricyclic antidepressants like amitriptyline. Now, if those fail to provide relief, we move to second-line options, which include things like venlafaxine or tramadol. Topical treatments are also awesome localized adjuncts. Think capsaicin 8% or lidocaine patches, along with alpha-lipoic acid supplementation. But notice what's missing. Traditional opioids. We explicitly try to avoid them as first-line treatments because they carry massive dependency risks and, honestly, they just have much lower efficacy for this specific type of nerve pain.
The field is evolving so rapidly right now. We've largely mastered managing the pain and slowing the progression through glucose control. But as we look at really promising advancements on the horizon, things like nerve growth factor analogs, aldose reductase inhibitors, and even gene therapy, well, I want to leave you with this provocative thought. Are we on the verge of moving from just managing the symptoms to finally actually reversing the nerve damage altogether? Now that is the future of internal medicine.
Thank you so much for